Hi, good afternoon. I'm Derk Krieger. I'm a professor of neurology at Mediclinic Dubai and MBRU Dubai. And we're talking about advances in MS disease progression. These are the disclaimers. This is a educational event sponsored by Roche, and the remainder of the information can be read, and I'm going to move on. So this is our topic. We're talking about the various forms or phenotypes of multiple sclerosis. In terms of the disease disability on the y-axis, and then different phenotypes: the radiographic isolated syndrome, the clinical isolated syndrome, the relapsing remitting multiple sclerosis, the secondary progressive multiple sclerosis, and then as a different form, the primary progressive multiple sclerosis. And the onset of progression is conventionally seen as occurring over time with conversion from one phenotype to the next phenotype, excluding the primary progressive MS. As you can see here, in the next slide, we will be focusing on the transition of the remitting, relapsing multiple sclerosis to the secondary progressive multiple sclerosis, or if you wish, to define the beginning of a primary progressive multiple sclerosis that lacks the history of having had remitting episodes before. So this is where we're focusing on, and there is some interesting research done that I would like to share with you, which I think does have implications for our thinking of how to deal with this disease. So this is just a review without taking a lot of time. Everybody knows this. There is different pathology behind those different episodes and those different, I would say, epochs of the disease. So when you think of the acute relapse-associated damage, then you can see those big plaques in the brain, and here in the microscopic slide, where there is an inflammation that affects the axon and the myelin. And then later, in the later cause of the disease, there is delayed relapse-associated demyelination that can take place, or secondary neurodegeneration. So one is affecting more the myelin, and the other one is affecting more the axon and maybe even the neuron. So this happens, as we saw on the previous slides, over time. And if you think of the pathology, then the acute phases during the acute remitting phases are acute inflammatory changes. And then there comes this time in between where the secondary progression it gets initiated, where we may have either chronic inflammation and or secondary neurodegeneration. And all of this is added on the aging of the brain. And just to put it into perspective, aging of the brain means approximately 1% volume loss over a decade. In multiple sclerosis patients, it adds up to 3 to 5%. And this is the aging that is added on the chronic inflammatory and secondary neurodegenerative processes that occur during the disease process. So looking at this in a cartoon way, the acute inflammation in yellow happens early on. The firework, as I usually call it, the firework of the remitting multiple sclerosis. Some of these lesions that are not healing completely may turn out to be chronic inactive lesions or maybe lingering lesions. Chronic inflammation may occur close to the leptomeningeals as leptomeningeal aggregates that continue to trigger inflammatory processes. And then also the chronic inflammation, as I mentioned, smoldering plaques that may occur de novo or may be transferred from acute, not fully treated or healed acute inflammations. And then this goes on, as I said before, the acute inflammation is taken over from chronic inflammation plus the secondary neurodegeneration. And in this cartoon, it is already pretty clear that the secondary neurodegeneration may actually occur pretty early. So if we go back to this slide that we had with the different characteristics, so we don't know whether all of this happens in this interval that we're focusing on, or whether it actually happens earlier, even after CIS or even with RIS. We don't know. This is what future research will need to show to us. Also, we need to see whether a more aggressive treatment at earlier stages in the disease will prolong the progression-free disease progress. All of these things we don't know yet. All we know is that we have some tools that used in the overall remitting MS population, and also like Ocrevus in the primary progressive multiple sclerosis, do reduce the burden of disability. So basically what we're talking about is this continuation of the disease process with these, as I said, firework yellow events that occur that may be subclinical, that may be even under the threshold of the MRI detection, or they are relatively severe and they completely heal, or they heal to some degree, and then we have this continued progression of neurologic disability. So when you take this apart and further analyze this, then you can have relapse-associated worsening called RAW. So you have a relapse, and then within 90 days, or longer than 90 days, you continue to have a rest disability, which is that worsening that occurs immediately associated with the relapse. So this is a phenomenon that we know from our clinical practice. The phenomenon that we don't know so well, because we usually don't see the patients in this time frame, is if you have a relapse and then 30 days later, you see that there is a very, very slight worsening of symptoms that occurs, which we call progression independent of a relapse activity, or PIRA. So those are the two processes which are theoretically responsible for the continued neurological worsening of the patients. And this is just an example as how this could look like. You could start with the PIRA, then you have an acute event that ends up in RAW in the first depiction, and you can have another one here, and you can have another one here, and you have another event here that is actually completely healing. So there's this different flavor that the disease progress can have, but this pretty clarifies how RA and PIRA work together in the disease progression. So how do we define the PIRA in clinical terms? There is the EDS, the EDSS increase of more than 1 or more than 0.5, depending on where you look for the definition, or you have a abnormal 9-hole peg test, or you have a worsening in the gait as measured in the 25-foot walk. So those are 3 different domains that are being addressed in these tests, and a worsening of a patient with multiple sclerosis over time, as detected by these tests, would add to PIRA in the case of no relapse. And as a matter of fact, there will be an app developed, a telephone-based app that the patients can carry, where they are prompted to do 9-hole peg test equivalents and walking tests, as well as it being asked for symptoms. So there is an app in development that might be used by patients to help the doctor define or better depict PIRA in clinical reality. It's a little bit like using a diary for a migraine patient, so to get a better idea of how the disease plays out. And I think this is a very smart idea because it also involves the patient in the care process. So this is just the 9 peg hole tests. I don't want to go into details here. And then this is the 25 feet walking test that is standardized. And those are being used to detect PIRA in the situation. So the MS is a progressive disease from the start. We don't know exactly from which time point, but I think theoretically speaking, it should probably start with the first either clinical or even subclinical lesion within this disease. Continuity, and it is regardless of how it manifests. So how do we preserve the patient function? This is an important slide, and it distinguishes 2 different approaches. Either we treat in the beginning, for example, we treat with a highly effective medication in the early beginning of the disease in order to stop this PIRA from actually initiating if we believe that it does start from the beginning, or we just have a tool where we can identify the PIRA and then switch from one to a higher efficacious treatment as the patient goes along in the continuation of the disease. So this is basically the philosophy behind this. You have physicians who treat their patients hard from the beginning, and then there are the other ones that escalate the treatment as needed. And I think this PIRA detection tool that will become available is going to be very helpful in guiding, in particular, the ones that like to escalate their treatments. And what is the clinical evidence? Looking at these events, this is the original OPERA trial. And I'm going to talk about the extension in 1 minute. On the left-hand side is the control group, and on the right side is the ocrelizumab treated group. And these are these parameters that I walked you through in the introduction. This is the raw. So how much deficiency occurs with the actually relapse, and how much does occur without having a relapse, preceding the worsening. And then this is the disease progression, the clinically confirmed disease progression. So within these groups here, you can see the split in the interferon control group, and here you see the greatly improved performance in the ocrelizumab treated group. The raw is 2.9 versus 6.2, and the PIRA is 23 versus 18.5. And then the clinically confirmed disease progression over 6 weeks is 21% as opposed to 29.7%. So the contribution of PIRA and raw to the overall composite clinical disease progression is actually interesting. I wasn't aware of this. It is almost 80% of the contribution, and only 13.3% here is related to the residual after an event. So if we look now at the long-term reduction in the extended study, called OLE, then I would like to just move on. This is a slide that I like because of the coloring of this depiction here, because it resembles the German flag, but I don't really understand what is behind it. And so I just move on and explain it to you with the next slides. And this is the study. So the original study, the randomized double-blind 96-week ocrelizumab versus interferon study with each 800 patients, was followed by a 4-week screening period for the OLE, for the open label extension, where the patients on interferon were invited to receive ocrelizumab, and the ocrelizumab population was continued. It is interesting to see that only 37% of the interferon patients left the study. So more than 94% entered the trial, and from ocrelizumab it's even 97% of the patients. So it is actually a very high adherence to the protocol, given the changes that I just explained. In terms of the baseline information, I think there's not much important. Suffice to say that the OLE study here, the extension, has a slightly better mean EDSS score than it was in the beginning, probably because the patients that decided not to continue were the ones that were not doing well, and they were fed up with all of this and left the study. But that is just my interpretation. So it is quite similar in terms of the disease severity at the time of enrollment. And this is the continued, the EDSS-based disease progression within the trial. In the interferon group, 12%, in the Ocrelus group, 7.7%. And then after the patients were invited to switch over to ocrelizumab, you can see that it is actually parallel. So the gains that were made, so to speak, with using ocrelizumab over interferons was maintained for the period of 336 weeks, which indicates that an early treatment is beneficial and will give substantial and relevant improvement when you compare the groups. And then if you look at the EDSS-6, which is basically when the patients need a walking aid. So this is when the multiple sclerosis becomes significantly bad. This is the same sort of scenario. There's 4% over 1.4%, and then this is also maintained over this period of the following 250 weeks or so. And if you look at the relapse rate, then you can see the same thing. There is a significant difference between interferons and ocrelizumab in the main double-blind trial. And then within the extension period, there's no difference anymore because the patients were both treated with ocrelizumab, whether they started with interferon or ocrelizumab. Doesn't make a difference. They fare the same in the extension period. And this is the 48-week CDP EDSS, which is a little bit more robust than a 24-week and even the 6-week used in the trial. So it is a very robust metric of showing that there is significantly less disease progression, in particular with early treatment when using ocrelizumab, in this case over interferons. And then this is the same depiction for the EDSS threshold of 6, which we talked about, and it's basically the same results direction. And then this is the side effects. And the side effects of significance, we just have to look into the Ocrevus rate within the trial, in the OPERA trial versus the OPERA extension population. And you can see here that there is no significant difference there, in particular when it comes to malignancies and when it comes to other serious side events in these groups. So in conclusion, over 6.5 years of follow-up, patients initiated with ocrelizumab earlier than those that were initially receiving the interferon had a significantly reduced risk, confirmed for 48 weeks, a period more likely reflecting permanent disability of confirmed disability progression on the EDSS score, requiring a walking aid. Switching from interferons to ocrelizumab at the start of the extension period was associated with rapid and robust reduction of the relapse rate that was maintained through the 4.5-year period. And the safety profile observed in the extension was generally consistent with those seen in the double-blind phase trial, and no new safety signals were detected. The effects of ocrelizumab on lessening confirmed worsening of disability, delaying the time to meaningful disability milestones, and reducing disease activity has the potential to positively impact patients' quality of life and reduce healthcare costs and burdens. So there is benefit of treating early with Ocrevus, superior clinical outcomes, significant suppression of disease progression independent of relapse versus high-dose interferons. So the clinical benefits sustained over time. There's a favorable long-term safety profile, and it is a twice-a-year dosing. So with that, I would like to thank you very much for your listening to me. Thank you. And thank you very much for listening to me. Bye-bye.